My name is Mary Gitau, and I'm happy to be here this evening and great to see all of us here. Thank you for taking your time and for coming over and for this session that we can be able to learn together and see how we can be able to work together to try and stop suicide. So Mary is my name, as I've said, and I work with suicide clients. And I have a passion to just make sure that we are able to sorry.
Hi, Mary. It's okay. We understand.
Yes.
We are all working from home. Yes, take your
Yes.
time. Yes, we understand.
Yeah, there's somebody who is making noise behind me. So I work with suicide clients, and I am a trained, I have been trained in suicidology. I'm a gatekeeper instructor, so I train on how we can be able to intervene and prevent suicide. And today I just want to take us through treating chronic suicide, because we all face this in one way or another. And at least once in a lifetime, if not every day, we'll always get clients who are coming to us that are having suicide ideation, suicide thoughts, that have attempted are attempting suicide, you know, and it can be passive, it can be chronic. So today we just want to see how well can we be able to treat this. So we have like 45 minutes to go. So I will just take us through the slides. Then at the end, if we have any question, we can be able to ask. Then we'll see how well we can be able to address it. By the way, all of us are learners, and I am also in the journey of learning about suicide. So when we get to the question and answers part, please feel free and let's all participate and we see how we can be able to go about this. So let me take us through the slides. So I'll start by saying this. At least one time in our lives, we've had somebody come to us and say, maybe in a nicer way or in any way, and they'll say to us, I don't want to be alive, but I don't always want to say this. Right now, I'm not actively thinking about killing myself. I don't have a plan. Actually, I don't even check all the boxes when it comes to the list of warning signs of suicide. I have a life I enjoy, and I'm curious about the future. And I even want to continue living. I don't always feel strongly about being alive though. And sometimes, particularly on bad days, I just want to go. I just want this to end. Once in a while, we keep hearing these words. Chronic passive suicide ideation is like living in the oceans. Remarkably enjoying the beautiful waters, at the same time stormy, you don't know how you'll survive. That's the life that most suicidal patients experience. One time they're feeling good, the next time they're feeling, I can't take this anymore. So let's start by defining what suicide is. So Sigmund Freud, he said that suicide, he called suicide murder turned around 180 degrees. A very poor response to a very bad day, or what he calls self-murder or self-killing. An act of deliberately or intentionally taking one's own life. It's an attempt to communicate or solve a problem. It is unresolved psychic and alienation. Psychic is very painful psychological pain that nobody can be able to explain apart from the person who is feeling it. So this murder, self-murder or self-killing, is what Sigmund Freud is calling suicide. He continues to, and we continue to learn about suicide behavior. Suicide behavior can be categorized into three. That is suicide itself, the self-injuries act intended to end one's life, which results in death, self-inflicted or intentional injury. There's also attempted behavior where potentially self-injuries act intended to end one's life, but which does not always result in death. Then we have suicide ideation, which is thinking about engaging in a suicide behavior or plan with or without a specific plan. So when it comes to ideation, you're thinking in engaging in suicide. You could be having a plan, or in most cases, the patients do not even have a specific plan. It could go on for so long. And in most cases, days, weeks, months before it actually even happens. So categories of suicide. We have the impulsive suicide and planned suicide. So in impulsive suicide, which just happens, you're in a state of crisis, or the client is in a state of crisis, and all of a sudden something triggers and they just take a rope, a gun, some pills, and they just die. Simultaneous thought as a response to a crisis or trauma, loss of capacity to rationally control emotions, thoughts, and behavior at that particular time. The perception that they have of trauma or meaning or significance of the crisis that they attach to it. So when they're going through this and they have attached a particular meaning to what is happening in their life, that could trigger an impulsive suicide, and it could happen even without warning. How about planned suicide? Planned suicide is one may not be in a state of crisis at that particular time, or they could be in a mild state. Why? Because they have thought, they have planned about this for so long. Even the behavior actually appears calm. The person is focused and thoughtful. Their thought process are rational. They're determined to solve the problem regardless. Now, most of the clients that come to the therapy room, they have already, so the people that come to the therapy room are not those who've decided. The ones who've not decided are still thinking, okay, should I go for this? Should I not? Those are the people that come to the therapy room. They're just having ideations. And that's why most of the time when suicide happens, we are there and we are saying, we actually didn't even know that this person had thoughts of suicide. Why? Because they had thought about it for so long. And that is why at that particular time, or the days before, they appear calm, they're happy, they're even engaging with people, they're eating well. But then at the back of their mind, there's this what they have decided to do. Even their behaviors, even as we interact with them, they appear calm. They actually appear focused at that particular time. And that is why when suicide happens, we say, wow, what really happened? I actually didn't know that this person was thinking about suicide. Suicide thoughts or ideations, what are they? So active suicide ideations, the desire or the urge and the plan that somebody may have. They're so active that they even say it to themselves, I want to kill myself, or I want to end my life, that particular time. Then we have the passive suicide ideation. This is the urge. They just have an urge. And they keep saying, I think I would be better off dead. Or I just hope that one day I'll sleep and never wake up. And you know what? And in most cases, we don't know how these people live. They actually live in kind of a gray space between fleeting about thought and attempt. And those dealing with passive and active suicide ideation don't even come out. And that's why even in research, we don't have concrete research about people who have suicide ideation or thoughts. Why? Because those who are having suicide ideation or thoughts, in most cases, they'll not even be counted because of the stigma. When somebody mentions, I want to die of suicide, people are looking at you and are thinking, what? And they actually just leave you and they walk away. So that is why when it comes to research, these people are not factored in. But we know that for every person who dies of suicide, many others attempt and many others are still thinking about suicide. And like, for example, when you have suicide of celebrities, the days following the death of a celebrity through suicide, we have many others that die through suicide. Why? Because those thoughts were there. And this celebrity who has died, people want to identify with them. But because we are not so keen and we're just thinking about this person who's just died, and those who have thoughts, we don't keep them in mind. We get to know that the people who are actually having the thoughts and the ideation are quite many of them. Facts about suicide ideation or thoughts. Of individuals with a life history of suicide ideation, the probability of one making a plan is approximately 33%, while the probability of making a suicide attempt is about 30%. And of these individuals with a lifetime history of suicide ideation and a plan, the probability of attempting suicide was approximately 55%. This is a research that was done by PubMed in 2008. And among ideators without a plan, the probability of attempting suicide was only 15%. Consistently across countries, about 60% of the transition from suicide ideation to plan and from plan to attempt occurred the first year after onset of suicide ideation. So from the time somebody starts having thoughts or ideation of suicide, within 1 year, they'll probably have made an attempt or they'll even have completed suicide. So we need to watch out. What is this that triggers suicide ideation? How do we treat this chronic suicide ideation? Because we will always have these people with us. And even when they come with other conditions in the therapy room, some of them are having suicide ideation, but they don't know how to talk about it. And so that is why we want to know and see how we can be able to treat suicide ideation. So suicide ideation or chronic suicide ideation, what is it, or what do we mean when you're talking about this? It takes many forms, and it can be, for example, like just fantasizing about, dying or passing during sleep, developing like a terminal disease, dying in a tragic accident, or just like you're having background noise of death and voices that are whispering to you and kind of encouraging you to go ahead and die. And at times it hits some people only in the dead of the night or when they've been drinking, so much. Others completely at random. It just happens. And within a flash, they just can't wait. So it persists for a very long time, or it keeps recurring. This is what you're saying today, and we hear it day in, day out. You have this client who's been coming to you this week, and they come over to you next week. And what they said about you, about suicide this week, next week they'll still say, this is where I am. I actually don't think I can take this anymore. I just want to end it all, And the trajectory is similar to that of a person with any kind of chronic condition. We know about chronic conditions. At one time, we have flare-ups where it is far worse than normal, and then the symptoms subside, but only temporary. That is what suicide ideation does. Yet to others, the symptoms never subside. They live with their symptoms, and in this case, suicide thoughts, tragedy every day. For example, like even when somebody has, a terminal illness, like even cancer and all that, there are those times that people are in pain, tomorrow they're okay. Same thing that happens to suicide ideation and thoughts. So they live in this tragedy every day. For some, for so many years. For others, a few days. For others, a few weeks. And for others, just a few hours, and it's done. So common diagnoses linked to chronic suicide ideation. According to DSM-5, one of them is the borderline personality. We also have the mood disorders and substance abuse disorders. And of course, those people that suffer PTSD. And we are all counselors, we know how borderline personality works, we know how mood disorders work, and you know what substance use disorder and what that could mean to a client. all to a patient. So that is why even when it comes to treatment, you want to be sure that you look at the underlying cause of suicide ideation. How is this person? How is their mood? How is their substance abuse? So you want to look at that. Other factors that we want to evaluate when we are treating suicide ideation: hopelessness and the view of the future, helplessness and the sense of control, worthlessness, or the current life stressors such as conflict at home or work and coping capacity. For example, what we are going through even at this particular time with the COVID-19, we have so many people who got into a place where they're feeling hopeless. We have so many people who are feeling like they don't even have any sense of control. They're feeling worthless. Life stresses are too much. We have so much conflict at work. Others are losing jobs. Employers are not understanding how delivery of work is happening, and the coping capacity or mechanism has been interfered with. And so we are having so many clients who are going through suicide thoughts, who are having so many suicide thoughts, are having ideations of suicide attempts. And of course, we know those that are completing suicide each and every single day, each and every single minute. We keep hearing of that. And unfortunately, we don't get to hear this like in the mainstream media. We also don't even like have good data with us, but trust you me, what's happening is not so interesting. We're having so much of that happening. We also want to assess the history of psychiatric disorders in this person. As I've mentioned, according to DSM-5, the anxiety disorder, bipolar personality, PTSD, psychotic disorder, like the schizophrenia, substance abuse, and unipolar major depression. Now, for patients or clients who are having suicide ideation, most likely they will not self-refer. They will never get to that point where they will admit that they actually have a problem. And in most cases, they will resist treatment. And when they resist treatment, their best friend will often be drugs or alcohol or any psychological pain medication. This becomes their major friend. And because they have kind of put themselves away or opted to be in their own world of being alone, of avoiding people, that is why they opt to having drugs or alcohol as their friends. And they know how to hide their level of despair. And they'll always go undetected, meaning they'll always go untreated. And why undetected? Because even us as counselors, we're human beings. And anytime like we are confronted by even somebody who is thinking about suicide, the first thing that happens to us is probably fear, then denial. Like you are more or less like, are you serious? You know, even when you're talking to friends or to colleagues or to family members or to people that we know and they mention about, they have been thinking about suicide or they're just feeling they're tired and they're worn out, the first thing that will come to us is anger, probably fear, anxiety. How do I deal with this as a counselor? So, and because of that, then we find that most of the clients that have suicide ideations and thoughts, they go undetected and they go untreated. Why again? Because in most cases, we'll always be in our therapy room, probably waiting for these people to come. And as we continue waiting for them to come, they will not self-refer. They will not come. So, and that is why, so so nowadays we are talking about suicide so much, meaning the stigma is kind of going down, but then the suicide cases are going high. What then does this mean? That the stigma is quite low. It is not as it was years back. At least now we are talking about suicide. It's not like the way it was like 10 or 20 years back. Now we are talking. Now it is, even in the mainstream media, it's being reported. So the stigma is not as much, but then why are we having these suicide cases go high? It's because we are not, the suicide ideation or thoughts go undetected and untreated. And then after some time, it just happens. So dangers of chronic suicide ideation. It signals despair or hopelessness or other painful states. The person who has chronic suicide ideation is in a desperate place and feeling hopeless. And they're actually having very painful psychological effects. It desensitizes the person and increases the capacity for self-harm. You know, the more you continue having the thoughts, the more the pain or what you're going through continues, then it increases the capacity for self-harm. And that is why, like, even when you get to see people who are self-harming without even intentions of suicide, they say that as they continue doing the self-harm, they kind of feel relaxed. They kind of feel better. That is because they're going through very painful very painful moments, and the best they can do is just continue harming themselves. It can create stress in relationship with others. Imagine if this is one of the people you're living with in the house. As you continue or thinking or planning about suicide, the suicide thoughts, it creates stress in relationship with others. I know of a certain couple who, this lady actually took the husband to the hospital and said, me, I'm not going back home with him. And like the doctors, and he's saying, no, I know, yes, I have been suicidal, but this particular time I'm actually not feeling it and I'm okay. So me, I'm going home. And the wife says, no, there's no way you're going home. Everybody's stressed about you and we just can't even allow you home. You have to stay in this hospital. And the people in the hospital are insisting, this person is okay. But the wife says, I am not taking him home. You guys have to stay with him and you have to treat him. And you see, that's the stress that this spouse was feeling. And for her to even take the initiative of bringing the husband to hospital meant that everybody in the house was being affected. And so she had to kind of take an action of taking him to hospital and even deciding, hey, I'm not going back with you. You have to remain in hospital. And of course she insisted, and the doctors, the nurses, they all thought that she was not okay. But finally they agreed to admit him in. And when they did admit him, the guy actually confessed and said, yeah, like a week prior, he had actually done a life insurance. He had even bought a gun specifically for killing himself. He had even done a suicide note. So you see, suicide ideation, and when they become chronic, they create stress in relationship with others, and the entire family or everyone that is around you gets affected. It impairs functioning for some people. So those people who are having suicide ideation, even as they continue working and everything seems to be okay, but somehow for those people who are keen, they'll notice, hey, this person is quite not okay. I think something is not right. So these are the dangers of chronic suicide ideation. So what are the treatment modalities? So before we look at the treatment modalities, this is what I have said, that the treatment modalities for suicide ideation, one, should be person-centered. The client who's coming should be the center for the treatment. They should be collaborative between the therapist and the client, and should acknowledge the ambivalence that the client is contemplating suicide. Why? Because this client has come in. So it should all be about him. Whatever we do as therapists should be geared towards helping this person. what we want, all we need is to explore why they want to die. We shouldn't focus on stopping them so much from killing self, but rather finding out or trying to explore what is this that is making them want to die so much. And the biggest mistake we make is we focus on stopping this person from killing themselves without actually looking at why do they want to kill themselves. And so the modalities that I'm going to talk about are the modalities about how do we go about exploring about why this person wants to go ahead and kill themselves. So the focus should be why this person wants to die. So informed versus uninformed therapy, which can make the difference between a life saved or premature death for someone who cannot bear their suffering any further. That's what we want to focus on. So what are these treatment modalities? So I'm going to talk about three. And these three CT, cognitive therapy for suicide patient. Then the other one is DBT, dialectic behavioral therapy, then the CAMS therapy. So the CT, cognitive therapy, which is based on Aaron Beck's CBT, it is structured and time limited, like 10 sessions between the client and the patient. It has an early phase, which includes treatment engagement, risk assessment, and crisis management. So for treatment begins with the therapist completing like a thorough suicide risk assessment, which includes gathering relevant information. You want to look at the crisis intervention strategies, such as like developing a safety plan and conducting means restriction, like ensuring that the means that this person wants to use to die have been removed or are not near them. That's what we want to do at the early phase of intervention when you are using the cognitive therapy for suicide patients. So we want to complete a suicide risk, we want to do a complete suicide risk assessment. We want to gather information about this person. Where are you based? What do you do? What's happening? Just getting the ideas about this person. And ensuring the crisis management, ensuring that the means, are you wanting to use a gun? Are you wanting to use a rope? Are you wanting to use pills? Are you having time? So you want to remove that and just make sure that the client doesn't have that. Then we have the immediate, intermediate phase, which includes behavioral strategies to help develop cognitive, behavioral, and affective coping skills. So what basically this means is that you want to look at the behavioral strategies that would help this client kind of develop coping skills that will help them, that will keep them alive for longer. Then when it comes to the final phase, which we're calling relapse prevention exercises. So you keep teaching the client about how they can be able to prevent, like when you feel about suicide, what do you do? What exercise do you engage in? Because according to this theory, an individual biopsychosocial vulnerabilities can interfere with the suicidal thoughts to provide to kind of produce what we call a suicide mood. So you want to ensure that the exercises that you're teaching has to do with their behavioral, their cognitive, and their coping skills, and just empowering them and making sure that they're well taken care of. So the therapist kind of guides the patients in even obtaining a narrative timeline of the most recent suicide thoughts and ideation. Tell me when you started thinking about this. How did you come to this? What did you do about when you started thinking about this? All that. You want to engage them completely, and you want to hear everything that they have to say about this whole thing these ideations, these thoughts of suicide, when did it happen? When did you start thinking about it? How long have you had it? Is there anybody around you who knows about it? Do you have a friend? Does your family know about it? Who are you staying with? You want to focus on all that. Then the other evidence-based psychological treatment is the DBT. DBT was developed by Marsha Reinhan in 1993. And one of the reasons why he developed this is it was basically like to deal with those clients that have issues with borderline personality. So before I talk about DBT, what's the difference between CBT and DBT? A few, I'll just mention like 3. So CBT is cognitive behavioral therapy, is based on the idea that our thoughts and behaviors influence our feelings. That's what we've learned about CBT. Changing the way we think about and react to situation will help us feel better. That's CBT. CBT also focuses on how our thoughts, feelings, and behavior influence each other. How do our feelings, our thoughts, and behavior influence each other? Then CBT also seeks to give the patient the ability to recognize when their thoughts might become troublesome and give them techniques to redirect those thoughts. That's what we do in CBT. We want to work with the client or the patient to try and recognize these thoughts that might become so troublesome. So what about DBT? DBT focuses on helping people change their behavior patterns, as opposed to trying to think or talk through the issues they're struggling with. So the emphasis when you're using DBT is about mindfulness and accepting the situation and the pain you are in. So the DBT helps patients find ways to accept themselves, feel safe, and manage their emotions to be able to regulate potentially destructive or what you call harmful behaviors. That is what DBT does. And it has been proven to be very effective at reducing suicide attempts and suicide ideation. Why? Because it targets suicide behaviors, and it targets at those behaviors that interfere with the treatment delivery and the other dangers, severe or that could destabilize the behavior. Because we want to make the patients kind of deal with their emotion, regulate their emotions. That's what DBT does. So there's the talk therapy in CBT, then you add the DBT where, yes, these are the emotions, but then how do you deal with this pain? How do you work through this pain? As opposed to, and that's why I talked about it should be about based on what is causing you want to die so much? What is this? We want to find out what is this? What is this particular thing that is really pushing you to this point of wanting to terminate it all? So standard DBT addresses the following function. 1, it increases the behavioral capabilities of this person with chronic suicide ideation. Then it improves motivation for skillful behavior through contingency management and reduction of interfering emotion and cognition. It assures generalization of gains to the natural environment and structures the treatment environment so that it reinforces functional rather than dysfunctional behavior. So we want to reinforce the functional behavior rather than the dysfunctional behavior. And we want to enhance you as the therapist, the capability and motivation to treat the patient effectively by not stopping the client to kill themselves, but by looking at those functional behaviors and issues that are pushing them to the limit of wanting to kill self. Then you have the CAMS, or what you call the collaborative assessment and management of suicidality. So the CAMS therapy, it focuses on the suicide drivers. these are the leads that lead somebody to wanting to kill themselves. And how do we do this? We use what we call the SSF form, which is a suicide status form, which is a 7 to 8 page form. So it was developed by David Jobs, and it emphasizes on stabilization plans and suicide drivers. What are these leads? It quickly reduces suicide ideation because we focus on the leads, what we call the drivers. And as you focus on what is causing the suicide ideation, then you increase somebody's hope and you give them reasons for living. It also improves clinical retention. Why? Because both the clinician and the client engage and cooperate in assessing and managing suicide thoughts and behaviors. And I'll keep emphasizing that we want to look at this lead. And so if you have a look at the suicide status form, it guides the client assessment and treatment, and it is developed collaboratively between the client and the clinician in the course of therapy. This was the idea by David Jobs, that looking at these drivers to this client that want to terminate their life. So you want to look at that, you want to deal with that, you want to help the client that. But now the question is, how do we do it? So I've indicated that the very key to treatment is listening skills is very key in intervention. Listen, take all the time to listen to the client. So when they come in, how do you do it? Listen to them, just hear them out. Even if they start talking about what's happening around them, you want to take all the time and listen and hear them out. Then after they stop talking, then you could ask them the question, are you planning to kill yourself? And I know it's not an easy question. Asking somebody if they want to die by suicide, and being very specific about this question. You want to die, you want to kill yourself, how do you plan to do it? When do you plan to do it? What are you going to use to do it? The specific questions, not going around the bush. Let's ask them specific questions, because when at times we avoid asking the direct question about killing themselves, there's a high probability they'll deny that, yeah, maybe that's what I was thinking, but actually maybe I'm not thinking about it. But if you ask them the specific question, they'll say, yes, I'm actually thinking about it, though I may not have an idea of how to go about it, but I actually am thinking about it. So we want to ask the right question at that particular time. Don't postpone it the moment they come. Even when you're having this borderline clients come to our therapy room, the clients who are having depression, PTSD, they're going through stress, you will even ask them, I know during these times, a lot is happening. Are you by any chance thinking of ending it all? Are you by any chance thinking about killing yourself? Talk to them and let them tell you. I know that, yes, I understand that you've lost your job. Since you lost your job, have you been thinking about killing yourself? If we ask the right question, then we will know even how to go about treatment and which treatment will work for them. If you are unable to treat or to even ask these questions, please refer as soon as possible. Don't insist in treatment if you have a struggle as a therapist. And why I'm saying this is because, what happens is that when we have suicidal clients, we tell them, go see a therapist. But then, do these therapists that we tell clients to go to have the right training to treat suicide or to treat suicide ideation? Do they have that? Many of them may not have gone through specific details of how to work with a suicidal patient. So the human way of what is happening is you're having a suicidal client who's sitting in front of you and you as a therapist, and they're telling you how they want to kill yourself. At the back of your mind, you're thinking, oh no, I'm also scared. How could you? Why do you want? So you're having so many questions going through your mind. There's fear in you, there's anxiety, there's unsurety of what do I do? How do I go about it? So that's why I'm saying, if you're unable to do it, if you're unable to even ask these questions, because you could also be a suicide survivor, like a loss survivor, where you've either lost someone through suicide or somebody who's died through suicide. So you may not even be able to know how to go about it. So as soon as they come to you and you're unable to do anything, kindly refer. Then take care of yourself as a therapist. Taking care of yourself means seek supervision. You don't have to, even if you can be able to treat, make sure you're doing it, you're being supervised, or you are having a conversation with somebody about it, because you might also carry the struggle of this person. So take care of yourself as a therapist when it comes to dealing with suicidal clients, because as I said, chronic suicide ideation keeps coming. It's like a terminal illness. Today you're on, tomorrow you're off. So you have these clients who, today they tell you they're okay, tomorrow they tell you, this is what I'm feeling, I just can't take it anymore. So you can imagine having such a client for months, years. You can also feel drained. You can be drained. And that is why, if we can be able, as therapists, just seeking the right, even going for more training on getting more knowledge on how do I go about this, I think that would also be helpful. So other tips and techniques: treat chronic and acute suicidality different. Identify which one is chronic that needs immediate attention, maybe it's hospitalization, maybe you need medication. Which one is acute that needs to be, to go through therapy. But all of them, they need to be taken with seriousness they deserve. Avoid power struggle. Don't insist the person stops thinking of suicide. Never insist to a suicidal person, stop thinking about suicide. Don't tell them that. The reason why they do suicide is because they want to run away from the pain they're going through. The pain is unbearable, and that's why they want to walk away from it. So suicide is actually not the thing to focus on. Rather, you want to focus on the why. So don't insist that they stop thinking about suicide. Use crisis intervention only when needed. Involve family. Be mindful of unhealthy dynamics. Examine functions of suicide, suicide ideation, and suicide-related behaviors. What I mean is, be very conversant with what we mean by suicide and suicide ideation and other suicide-related behaviors. Foster acceptance and observation of suicide thoughts. As a clinician or as a therapist, as a counselor, as a medic, foster acceptance that suicide is here. People have ideations, people have thoughts of suicide, and people attempt suicide. That, just accept that first. The moment you accept that, so even when you hear it in the therapy room, you will not question, you will not start thinking, how could you, what is it that you don't have? I thought you have a job, a good family, how could you, because you've done the intake form and you've seen everything about this person, then they are coming and saying, I actually have thoughts of suicide, and you're thinking, why, how? Foster acceptance. And on the last point, number 7, practice self-care. Therapist self-care, insisting, challenge your expectations of control and care. Maintain hope as a person, and don't practice in isolation. Consult and seek supervision at all times. Wangoi, over to you. Thank you so much.
Wow, thank you so much, Mary, for that. I am wowed by the depth of knowledge in the presentation. And I'm reflecting. I was here and there, but I was able to get a few things here and there. But I'm realizing one of the things that you said is many of us, when you're going through the basic counseling course and knowledge, we don't have the in-depth knowledge on how to treat our clients with suicidal ideation, and yet we are coming across them and they're coming our way. So having this knowledge, somehow we have the capacity now to be able to address this. But I want to open it up to us who are here. And I've seen some questions in the chat section, and I know Mary is in a hurry to go to something. She has an engagement. So we're going to have a few questions from those of us who have questions, and then we're going to respond. But as we said, we are all learning. She also says she's learning, so we are all learning from this. So to be able to hear, one, as professionals, what challenges do you have when you're having clients with suicidal ideation? How do you go about those challenges? And I think one of them, Mary, maybe you can even shed light on this, is the idea of the criminal element in terms of somebody attempting suicide is treated as that is it requires them to go to the police. So I don't know how you go about that. Yes.
The question is to me?
Yes, it is to you, but also everybody else in the platform is welcome to be able to share in. Mary, you can start us off.
Thank you, Helen. So about somebody having suicide, especially suicide attempts, and being taken like a criminal one, of course, the government has the right to protect life, but then just taking the person in won't help in any way. It actually makes things worse, because you see, I have said in the presentation that we don't insist, the power struggle, we don't insist that this person stops thinking about suicide. When you take them in as criminals, what we're telling them, stop thinking about suicide. Stop killing yourself. But then we didn't address the real issue. So what happens? This person, yes, will be taken in. But remember, we didn't deal with the root cause or the issues that were behind them attempting suicide. So even if this person stays in that place for 1 year or 6 months or 3 months or even a week, and they come out, the thoughts, the ideations never go away. So high probability they will attempt it, and high probability they will succeed at one point. So, and when they get released, we don't know, like us as therapists, most of the time they are taken in, but when the moment of them coming out or being released, we don't know. So they go their way. We also don't know, because we don't have those data, we also don't know whether, in most cases, we don't do follow-up. So what happens is these people go, they still continue struggling, and at one time they actually complete it. By the time you come to realize, you will realize, oh, this is at one particular point, this person was actually jailed because of attempting suicide. You know, so it is, and that's what I'm saying. Let's be open. Let's also be on the lookout to look for people who to identify people who are having thoughts and ideation. When people are struggling, let's have the direct question to them: are you thinking about killing yourself? And let's hear from them.
Hi, thank you for that, Mary. So if we have questions, I'm seeing many of them come in the chat section. If you have a question and you want to ask, you can put up your hand, but we will start with the chat section. I read some of the feedback and some questions, and I know we may not have time to respond to all of them, so I'll see how we can connect more with Mary. Yes. There was one from Vespas earlier on, and he says, this has come in handy and timely because he's learning every day. He says, I am handling a suicide client at the moment. I have hated why the doctors, nurses, and clinicians in our hospital who have always been blindfolded, thinking clients are meant for them. Okay, so the information is very handy for him. Someone else is saying, okay, a very timely session. My nephew committed suicide 2 weeks ago, and we are left with more questions than answers because no one saw it coming. So the element you discussed earlier on of the planned versus the impulsive suicide. Thank you for the presentation. People are appreciating the presentation. It was very well articulated and researched. Okay, should we ask a why question or what question to avoid the client being on defense? Okay, about the questioning, asking the client if they are planning what is making them be suicidal. Lillian says this is helpful. Currently handling a suicidal client, and I agree it can be emotionally draining, hence the need for self-care, which you have really emphasized. Agnes is saying, when the client says they have put themselves on suicide watch, are they suicidal? So Mary, allow me to read all of them, then you can respond.
Yes, I'm noting them.
Okay. Okay, Purity is asking, have you had a suicidal client actually go through with it, and how did you handle it? Is there an issue between parenting styles and suicidal ideation? Dr. Margaret Maura. Janet, what do you do with those who have already attempted suicide, but by God's grace they survive? And then Purity, for clients with active suicide ideations, do you release them to go home or admit, and what informs this decision? So for clients with active suicide ideations, do you release them to go home or admit, and what informs this decision? So more appreciation for the well-researched job. Great job, Mary. Okay, someone is saying there's an initiative by the Mental Health Task Force to decriminalize suicide, change the language from committed suicide to died of suicide. Very good for that, Sarah, for clarifying that. I'm trying to see more questions here. Okay. For the person who does not show any suicidal symptoms, how do we do today? Okay, how do we know they want to kill themselves or to die by suicide? Florence is asking, where a client was a suicide ideations kept secret from the family, how do you disclose to the family? So the family is not aware the client is having ideas on suicide. So how do you disclose that to the family? Naomi, I've seen your question. I'm not sure, but thank you. Over to you, Mary, for those ones.
I don't know. Okay, I don't know which question to start with. So I think the suicide watch, the person who said that they're on suicide watch, you want to be very careful about this person. The moment they are saying that they're on suicide watch, remember what I said to you when you were starting. Like having suicide ideation is like being in an ocean. Those days that things are okay, you actually want to swim, and there are those days you're wishing you could just drown. You even tell the therapist, today I'm feeling okay. I have no thoughts. Everything is, I actually enjoy life. I actually want to hang out with my friends over the weekend. But then when they go to bed, something could just happen and trigger that. So you want to be very careful about this person. And that is why I said about when you want to confront a suicidal person, you want to ask them, are you planning to kill yourself? Have you thought about killing yourself? When you thought about killing yourself, what did you have in mind? Like, what did you want to use? Have you mentioned to anybody? Have you written a suicidal note? You want to ask them about that. So that person who is on suicide watch, you do not want to leave them away. And that is why at this point, we break confidentiality. I'll tie this with the person who asked about, do we tell the family? As much, yes, being mindful of the family system and the dynamics of the family, we are mindful of that with this client, because could be the drivers of the leads of suicide are coming from that. But then we can't keep quiet. We must let somebody else know. Of course, it means we don't work in isolation. Consultation or supervision, including involving the hospital, like admitting this person. So at what point do we even know that we need to admit this person? When somebody has a plan, if we let them go, they will execute it. And those people who have plans, remember, they don't actually, the moment they are known that they want to do it, and where we are coming from as a country, they know that this is a criminal, they can actually be jailed. They would rather be away than be in those prisons. So you want to say, this person is actually having chronic suicide ideation without giving them details. Chronic suicide ideation, we have to admit them, we have to give them medication to calm their mood. so that we can even start therapy. So we want to, what informs admission is when you're doing assessment, using the SSF form or any other form, you will gauge the boxes they tick in SS form. They will tell you where is this person when it comes to chronic ideation. How badly are they? And you admit them. But when it is acute, remove the means. Just remove the means, but make sure that you're watching them. At least any person who having suicide ideation should have people around them should know that this person is thinking about suicide. So we cannot neglect them. And it is like, even when you're asking, like, for example, I'll talk even about children. You know, at times we are thinking, should we even ask questions about, should we even talk to children about suicide? Yes, we should be able to talk about suicide with children. And we should even ask particular questions about death to these children who are thinking about suicide. So if a child is even having suicide ideation, you will even ask them direct questions. And for example, you'll even ask them, like even when the parent comes and brings the children to maybe in the therapy room, you'll even want to ask their parents, what exactly happened? Tell me step by step on the day that your child spoke about wanting to die or wanting to hurt themselves. How did you find out as a parent that your child was thinking about or trying to hurt themselves? What were you doing as a parent? And what happened even after a child thought about it? You want to ask them step by step. If it is a child, you want to ask them, tell me, did you tell anyone that you wanted to die by suicide? Did you do anything to try and get yourself killed? Was anyone near you even when you wanted to, or when you tried killing yourself? So very specific questions. And when you're asking these specific questions, they will, you know, you're asking them following each other. So even if they deny the first one, the next one they'll not deny, because you'll be confronting them. But then you go around the bush, there's a high probability that they'll try to run away from the questions. Have I tried answering them, Helen?
Well, I think you have. But what I'm hearing is that one, it's something which we can't be afraid of confronting or addressing the issue as it is. We can't run away from that. It may be uncomfortable, it may be difficult, it may sound insensitive, but we can't run away from that as professionals. We have to be willing to be in space. Yes. And I think, first of all, we have to deal with our own fears and concerns around this whole topic of suicidal ideations before we even have now to deal with the clients. We have to really practice.
Yeah, and you see that, and you can even ask in a very indirect approach, like asking the client, so after losing your job, were you so upset that you wished you were not alive or that you wanted to die? You know, you're coming it from the lead or the drivers of suicide. When you lost your job, when you got that termination letter, were you so upset that you wished you were not alive? You could even follow up and ask them, did you ever do something that was so dangerous that you could get hurt or get killed after receiving that termination letter? When you got that demotion at your workplace, or when you got that rejection from your spouse or boyfriend or your parent, or did you ever hurt yourself or try to hurt yourself? And did you ever think about trying to make yourself dead? You know, so you're addressing the lead. So when you're talking to them about it, you're asking them the question, but starting from the driver of the suicide. Because the issue, what you want to address is you want to address why they want to die. Yeah. To you, Helen.
Thank you, Mary. Mr. Clement Cheriot, I see you have your hand raised. I'm going to ask you to unmute. You can make your question or comments. Clement Cheriot.
Yes. Let me appreciate the presentation. I think it's well prepared, it's coming from a professional. I wanted to touch, I don't know, you can hear me?
Yes, we can.
Yes, I wanted to touch so that we are also very careful we don't play into the hands of stigmatization, referring to the criminal aspect. I would rather use the legal and ethical obligations that we have as psychological services providers, which would actually refer to our duty to either to protect or to inform. I'm a bit uncomfortable using the word the criminal aspects. I think it's more the legal and the ethical, whereby we assess the client or the patient, and if they are a danger to themselves, or even in some other cases, a danger to others. So I think they are in ethics or in professional ethics or the ethical and the legal, that kind of language that would remove what we are saying. Because when people are sick, they need therapy, they need treatment, not criminalization. Let me also appreciate what the presenter on the issue of fostering acceptance. I'm saying so that we validate. I think she brought that point very clear. We validate. When someone is expressing the urge to end their lives and all that, we should not minimize, but we validate their feelings. As I end, I also wanted to mention, I think she talked about the impulsive and the planned suicide. I think the most dangerous one that sometimes we miss is the impulsive. But these ones that have plans, I think if we are very perceptive and sensitive enough, and we can read all the signs, I think those ones we can save. Thank you for the presentation. Thank you also, Ellen, for the moderation. I appreciate the time you have given me.
Thank you, Mr. Clement, for that clarification and for your feedback. Mary, how much time do we have more with you? So I can know to read or to pose there. There are more questions coming in.
We can go to 7:15. It's 7:07, yeah.
Okay, perfect. Okay, so someone is saying, I have a 10-year-old boy committed suicide. So we've been told the language is, Mary, the language is?
Died by suicide.
Okay, so a 10-year-old died by suicide 2 weeks ago, and everyone wonders why. How will the parent tell that the boy had suicidal ideation? So that is one. Then this is a feedback to a question asked earlier on about the ethical requirements to break confidentiality with regard to a client. Thank you, Lillian, for that clarification and feedback. Agnes says, I have a client who has been attempting suicide upon triggers, but has never completed. Are they seeking attention? Sisha says, please advise on the clients who are both suicidal and homicidal, and the only way out is suicide. Is it only an exit plan? Moffat is asking, a suicidal client once told me that seeing a grave soothes a mind. It was therapeutic, just enjoying the excitement of a grave. Can you explain this? Francis says, I think therapist's role is to pacify suicidal ideations by empowering the client with coping skills and beefing up hope. Okay. Okay, there's some feedback I had seen. Oh, Brenda has said, thanks, Mary. When I drank alcohol, I was very suicidal. Thanks to skillful therapists like you, I have believed not only to tell the tale, but to try to help others. Thank you, Brenda, for that. Moffat is saying, justice must be reconciled with health. It is us to educate the relevant authorities, including our parliamentarians and judges. Sick people go to hospital and not to jail. Thank you for that, Moffat. Sarah is saying the initiative of the Mental Health Task Force to decriminalize suicide change the language from computer suicide. Okay, yeah, that one I had read earlier on. So I think that is basically it where we are. Thank you, Mary, for that. Yes.
Mm-hmm.
Oh, yes. And for anybody who wants the presentation, I haven't mentioned, you send 100 shillings to the number I'll put in the chat section, and also indicate your email address. Yes.
Mm-hmm. So this parent whose 10-year-old died by suicide. So it's the parent. I think you want to talk to the parent as the therapist. You want to talk to the parent and ask the parent to take you through the last days. Like, so the child died like 2 weeks ago. So you want the parent to kind of take you through the last 6 months, the last 3 months, the last 1 month, and the last 2 weeks of this child. And you will be surprised that as they talk about it, they might discover some things. There was this young lady, she had actually a 14-year-old. Is it a 14-year-old child? So he was in school just before COVID. And so he called the mom and told the mom to go and pick him from school. He wants to come home. And he was feeling unwell, but when he got home, he was okay. And he got well, he was taken to hospital, and he started taking medication, and everything came back to normal. So he actually even went out, they went out for dinner. He went out and took his younger brother to, for an activity, and they had good time, and everything was okay, even watched his favorite program on TV. Then they had dinner, and this boy went to bed. In the morning when the mom woke up, the boy is not coming down for breakfast, and the mom goes up and checks, and the young man has died, and he had died by hanging himself. And the mom said, no, there was nothing, there was no indication that this child was actually planning to die. Zero, as in there was no indication. But then after 2 weeks, after the burial and 2 weeks went, the mom went to the room and just started searching what's happening, even checking the phone, the laptop. Of course, the searches came about his favorite game, and the mom saw that. Then at the time he died, at night, around 1 a.m., the mother noticed that this boy had started searching very specific information about dying. And the mom started talking about, okay, this is what happened immediately before he died. What had happened? And so the mother started going back during Christmas, what had happened? And kumbe, this young man had broken up with his girlfriend, and the mom didn't know, and nobody knew. But now his friends could gather information and started talking about it. This is what this boy was going through. So it is the parent who can take you through as the therapist to identify these cues. Remember, in suicide, we have those we call behavioral cues. We have verbal cues. So are there cues? Talk, verbal, anything. I wish life was normal. I wish the ground would open up and swallow me. I wish I was not part of this family. I wish, some of those things, those could be verbal, behavioral. Are there things that this child was doing, like giving out their things? Even how he related with other friends. Was he violent? Was he calm? So it's the parent who can help you to identify. But now your work as a therapist is to work with this parent to identify those cues. You're the one who is going to help this parent even identify those cues. Take the parent back. Take the parent to a journey back 6 months, 3 months prior to this death. Of course, triggers and attention. Remember what we said about suicide. The person who is suicidal is wanting to run away from hurt, pain, psychological pain, emotional pain. The pain is unbearable. So they're actually looking for an exit. They want to run away. And the only way of running away is dying by suicide. Remember, I think it was slide number 3 where we say that, what did we say? That they just want this pain to go away, and they will do whatever it takes for the pain to go away. And that's why I said, as a therapist, our role is to work with the drivers. What is this that is leading to suicide? So we do not want to stop the client from dying by suicide. We want to find out, we want to deal with what is leading them to wanting to take their own life. So it is, don't dismiss as attention seeking. look at it at what is causing, what is this pain, what is the struggle. Same thing to homicidal and suicidal clients and patients. There is a trigger, there is something, there's something that is happening in their life. That is what we want to deal with. Is there, could they be having a psychiatric disorder that needs medication, that needs to be admitted? You want to work with a psychiatrist so that you can identify those things. You want to work even with a medic. They could be having probably a physical condition. They could be having a terminal illness and you don't know. Is there something? They could be having some other conditions within them, but you do not know. The pain, the psychic, it is too much. And at times they do not want to talk about this pain. I long for the day that it will be so casual for us to just be talking about how we're doing, checking on with each other, that people will be so okay to talk about their struggles, that we will not get to the point of being suicidal, because the struggles that people go through will already be addressed. Helen?
Thank you, Mary. I think we can wind up that particular point. We can't exhaust all the questions in the comments, and many people are really grateful for your presentation. Insightful, very well researched, professional. And I think the point is we keep these conversations alive until we are able to somehow have the society aware of what is happening and how to go about